So continuing on looking at interventions for pulmonary issues, we have looking at delivering supplemental oxygen. So there's two tank sizes that are recommended for pre-hospital settings. Again, when you're looking in like the athletic training room, or if you're on a covering an event on the sideline. And just to kind of go over it a little bit as far as the procedure, and table 7.4 in your textbook just has the different steps as far as that, but just to mention some of the parts of the oxygen tank. You have your regulator attached to the top of the tank, and you'll have a pressure gauge and then a valve to reduce the pressure, and then just a flow meter. And you have your different delivery devices. You have the non-rebreather mask, you have the bag valve mask, and you have the nasal cannula. So they all deliver oxygen at a different rate. Your nasal cannula is going to deliver a low flow of oxygen. The non-rebreather and the bag valve mask both deliver high flow oxygen, and they go over there as far as the liters per minute that gets delivered with the different delivery systems. So take a look at that, and again, we'll get more in depth into some of the different ways in which and the decisions that go into what type of delivery system you would use. So in this picture, we have a picture of the nasal cannula on the left and the non-rebreather mask on the right. Again, the nasal cannula is going to deliver a low flow of oxygen, and the non-rebreather is going to deliver a high flow of oxygen. They also both deliver, they measure it based upon what they call the fraction of inspired oxygen, and they have that listed in your textbook, what the percentage is for each of the different delivery devices. Okay, and here we have just some illustrations of some other interventions. We're going to be talking in pharmacology about the different types of treatments. So you have your meter-dosed inhalers, you have nebulizers. If you look at the picture up here, so here's your bronchodilator, your inhaler that you typically have. Down here you have a nebulizer, and we'll talk about how all these treatments get utilized. So your meter-dosed inhalers are basically used to deliver medications directly to the tissue. So again, here we have, this is what would be considered your rescue inhaler for your beta-2 agonist. And then this here would be, this delivers a steroid directly into the respiratory region. Again, we'll have more discussion about the particular interventions when we get into the pharmacology lecture on respiratory conditions. Okay, so looking at our different conditions, again, make sure that you kind of take time for yourself and just, again, get the signs and symptoms of different things. Atelectasis, collapse of a lung alveoli. So this, you're actually having a situation where the actual alveoli collapse. This could lead to pulmonary hypertension or cor pulmonale, which and there are also an increased risks of pneumonia. Typically, you see this in individuals who are either bedridden or get a severe blow to the thoracic region. Okay, drowning and near drowning. So again, the big thing that occurs here is the water. The individuals have water aspiration, which causes them to asphyxiate. Various neurological and renal complications. Again, the determinants are going to be primarily the length of time they're in the water, and actually the water temperature as well. So the water temperature, if it's colder, they have a better chance of not having as much long-term damages because it lowers the metabolic rate. The cells don't need as much oxygen. But again, the fear here is the anoxia that occurs, the lack of oxygen. So you get a combination of damage to lung tissue, and you get that reflexive spasm of the larynx from the water getting aspirated into the lungs. A flail chest injury. So, a flail chest injury is when you're going to have multiple rib fractures at various sites, and you get what's called a free-floating segment. The thing that stands out with this is you get what's called the paradoxical excursion. So when the individual inhales, instead of the ribs and the thorax expanding, in the area where you have the flail chest, it'll actually sink. and then when you exhale, instead of the ribs contracting, you'll see that segment kind of pop out a little bit. So that's what the paradoxical excursion. So that's the easiest way to kind of pick up on this. But you can see in the picture here, they're showing you what happens. You can see, so here's your flail chest section. So in other words, as the individual would breathe in and the other ribs would expand, these would actually kind of sink. And then the opposite would happen when they would breathe out. These ribs would kind of pop out as the rest of the ribs would contract. So pneumothorax, attention pneumothorax, and hemothorax. So a pneumothorax is a collapsed lung. So that's when air manages to get into the pleural space. And the issue that happens is, remember we talked about how you have that negative pressure inside the pleural space is what allows the lungs to remain expanded and basically pressed up against the rib cage. That loss of negative pressure happens because somehow air gets into there, and that'll cause the lung, the side of the lung where, whether it's on the right or the left side, will cause that side to collapse. If you continue to get air collection, you end up getting what's called attention pneumothorax. So that air could continue to collect, and then what you'd actually start to get is pressure to where the trachea and the mediastinum, which is your chest compartment that has your heart and your other blood vessels, can start to deviate and start to push to the opposite side. So you can actually start to get pressure into that compartment, which can obviously cause a lot more issues. With blood, if you get blood to accumulate, which can happen as well if it's due to a trauma, you get what's called a hemothorax. So all a hemothorax is that the blood collects in the pleural space, and that causes the lung to collapse. So here's just a picture showing you kind of how all that happens. So, up here you can see the collapsed lung. So again, air manages to get into this space. You get that loss of the negative pressure and the lung collapses. Here they're starting to show kind of the start of attention pneumothorax. So if air continues to develop, so this space in between the lungs, you'll start to get pressure put in there. And here they're just kind of showing you the collection of blood and what that would mean for a hemothorax. Pneumomediastinum. So we talked about the mediastinum already in talking about the tension pneumothorax. So the mediastinum is the anatomic space between the pulmonary compartments. So you can actually get air spontaneously leaking into that region, and then you'd have a pneumomediastinum. And usually any type of forceful effort can increase pressure and cause that to occur. There's also some other conditions that kind of predispose individuals to a pneumomediastinum. So people with asthma, diabetes, certain types of drug use, people with anorexia or other pulmonary disorders can also be predisposed to pneumomediastinum as well. Asthma. So we'll talk a lot about asthma, and we're going to be discussing a lot of the pharmacological interventions for asthma. So asthma is an intermittent bronchospasm, and there's also an accompanying inflammation and edema that occurs that basically makes it, creates the breathing difficulty. Over time, if it's, particularly in poorly controlled asthmatics, you could end up having epithelial cell damage and possibly fibrosis in the bronchioles. So it's really important to manage this well so that the individual doesn't continue to have, further damage happen to the bronchi as they get older. Various causes of this. So, asthma itself is caused by genetic and immune factors, but then you have your other triggers, so allergens, cold, dry air, so that's an important thing. Humid air, warm, humid air is actually better and decreases the chance of having asthma attacks. Various drugs, emotional states can cause that as well. With asthma, a couple things about asthma, and I'm going to have you review these items. Make sure to have an action plan in place, and for the most part, athletic trainers are pretty good in having being aware of who on their teams have asthma. Make sure to have an action plan in place. And there's also a position statement which is summarized on table 7-8 kind of goes over just some of the important points that you'd want to consider when dealing with your asthmatic patients. So there's different things that you can do to help prevent asthma attacks and be able to monitor your patients accordingly. So again, just from a visual perspective, kind of showing what goes on with asthma. So again, you get that constriction of the bronchioles, a lot of the inflammation and edema, and you get the mucus formation, which again makes the airway much more narrow than normal. Exercise-induced bronchospasm, which is a little different classification. Now, people with asthma can have exercise-induced bronchospasm, but this could also happen in individuals with allergies. And this occurs about usually 5 to 10 minutes into a session. And they can actually recover spontaneously even without medical intervention. The difference between this and asthma is that there's no chronic irritation of the airway. So you don't have that inflammatory response that you get with asthma. Now again, individuals with asthma can have exercise-induced bronchospasm as well. So that's an important thing to note. And there's two reasons why they think, and they both kind of basically share the same mechanism. So again, the overall mechanism or issue is typically cooler, dry air and mouth breathing. And there's two theories as to what causes the issues with exercise-induced bronchospasm. So with exercise-induced bronchospasm, you have the water loss theory and the heat exchange theory. So basically with the water loss theory is that, particularly if you're breathing in cold, dry air, what happens is the airway basically gives off a lot of moisture to the air coming in. It causes this rebound in circulation, which basically causes the airway to sort of, again, close up and decrease in diameter. Same thing with the heat exchange theory, except now we're just talking temperature exchange. So, in reality, these things could both be at play. With the heat exchange theory, again, if the air coming in is a little bit cooler, the airway is going to give off heat to the air coming in. Again, rebound, increase in circulation to kind of warm the airway. And again, the same effect where the airway kind of closes up. Chronic obstructive pulmonary disease. So this is a disease, is a combination of diseases that involve partially blocked airways. So, bronchitis, emphysema, cystic fibrosis are all issues related to chronic obstructive pulmonary disease. So in the case of an acute bronchitis, it's an inflammation of the bronchi caused by infection or a chemical irritation. An individual who has repeated exposure to irritants can develop a chronic bronchitis. And then with emphysema is a condition where the alveoli get destroyed. So we know that the alveoli is where the oxygen and carbon dioxide exchange occurs in the lungs. And then that can destroy also the capillaries and just overall affect lung elasticity and really impair the lung's ability to be able to provide oxygen to the rest of the body. And again, here they're just kind of showing, in the case of chronic bronchitis, this is just a little visual representation. You can see the mucus and inflammation build up inside the bronchi. Over here, you have your alveoli. So this is your normal alveoli here, where, again, your carbon dioxide oxygen exchange would take place, coming to the end of the bronchioles. And then here's your alveoli with emphysema. And again, it's going to cause damage and elasticity to the lungs in general. Lung cancer. So again, primary association with lung cancer is smoking. So, cigarette smoking in general produces most of the, as far as like the lungs being a primary site of cancer or where it starts, smoking is very heavily associated with that. You could also have chemical exposure. In particular, some workplaces, years ago, there are certain chemicals and things that individuals can be exposed to. Asbestos is a very common thing you hear about as far as exposure causing lung cancer. Upper respiratory infections, so common cold caused by the rhinovirus. And again, we kind of all know some of our classic signs and symptoms with this, and some complications from common colds could be sinus and ear infections. So you could kind of get secondary infections in the sinuses and the ears as a result of a cold virus. They could typically last 7 to 10 days, and they're typically very contagious within the first 72 hours. There's various interventions that can be done in order to, to obviously help prevent upper respiratory infections. There's also some other things, we're not going to get a chance to talk about this, but there's certain things you can take that you can buy. For instance, there's Zicam makes a really good product that if taken within the first few days of a cold, it could really limit your symptoms and kind of shorten the duration of them, and shorten the duration of the illness in general. Influenza. So influenza usually starts to come around, usually around the fall season. Many individuals will go and get vaccinated, and the vaccination involves an attenuated flu virus. And usually what they do is they kind of look at trends and try to determine because there's a lot of different flu viruses, and they try to determine which ones are going to be the predominant which ones are going to be the predominant strains, and that's kind of how they determine how they want to do it. The transmission of influenza is primarily through respiratory secretions. Cystic fibrosis is an inherited disorder that affects the exocrine glands. It's a genetic abnormality that, again, primarily in the respiratory system, but it could also cause issues in the digestive tract as well. And what happens is it produces increased secretions, and really thick secretions from the glands that basically block the airway. And can cause a lot of infection. So it's very common for individuals with this to get recurrent pneumonia, and it can be very disabling and eventually be fatal as well. You could also block glands in the pancreas and intestines, which can, cause issues as far as digestion is concerned. So, sometimes that's the way it can manifest itself in some individuals. Basically, try with this to really work on pulmonary hygiene and antibiotic medications. Unfortunately, with this, it is very difficult to treat, and only about half of the individuals that get this live to 30. But with again, appropriate intervention, it could certainly prolong survival time. Neuromotor disease. So many types of respiratory disability accompanies a lot of chronic neuromuscular diseases. We're not going to get too in-depth into them because we're going to be talking about them when we talk about the nervous system, but basically we look at the neural control of breathing. And other things that could impact this as well are chest wall deformities. We have mentioned these at the beginning. So if you have a chest wall deformity, either whether they're congenital or acquired, they can restrict your lung volume. So you have to think about it. If you're changing the shape of the chest and thorax, you're going to be affecting your lung volumes, so that could certainly affect your breathing as well. So it's important during, when you're looking at a medical exam, if you do happen to notice any type of chest wall deformity, because then you could be looking at, different congenital disorders as well that could be contributing to the problem. Scoliosis is an abnormal curvature in the spine. Again, similar to what we talked about with the chest wall deformities, you're going to have a decrease in vital capacity and pulmonary function because it's going to be kind of changing the shape of the rib cage. So that's going to cause some breathing issues as well. And you can see here in the picture. So here's your normal spine, obviously. Here's your scoliotic spine. So you get a lateral deviation. You also get a twisting that occurs. So what that's going to do is basically, again, it's going to change kind of the shape of the thoracic region, and it's going to, again, just inhibit your overall pulmonary function. So, individuals who have really significant scoliosis, they could have some breathing issues, along with just, again, back pain in general as a result of scoliosis. So pertussis, or whooping cough, it's a bacterial infection, and what happens with whooping cough is that you end up impairing the function of the cilia. So in the respiratory tract, cilia are, again, those little hair-like projections. They kind of work to in kind of filtering the air and kind of helping move respiratory secretions. So the issue is if there's an issue with them, you're not going to be able to remove the respiratory secretions, and it's going to cause some further issues. The common thing you see with this is the long inspiratory cough, hence why they call it whooping cough. It can be asymptomatic during the incubation stage. Vaccinations, for the most part, have limited the prevalence of this, but it's also important to note that, again, this is usually going to affect young people much more significantly, and older individuals, older children and adults, typically when they get this, they get a much less severe clinical presentation, but they can pass it on to younger individuals, and those younger individuals can have a lot of complications with this. And these are your learning outcomes from the pulmonary system. So again, make note of your, for all your conditions, what are the signs and symptoms, treatments, and any return to play guidelines that are important.